So a very good morning to everyone. After that impressive peek into the future, I'm going to go back again to the very basics and a very common condition that all of us see in our clinics. I have no financial interest in the following presentation. So we all know that keratoconus is the most common ocular ectatic disorder, and the basic pathology is there is an area of thinning and protrusion, which is giving rise to irregular astigmatism and myopia, and the patient is having a very poor quality of vision. It is a progressive and a non-inflammatory disease. Now, what happens to the patients of keratoconus is that the structural abnormalities in the corneal layers as well as the altered tear film layer leads to a lot of halos and image distortions. So when these patients complain that we have poor quality of vision, sometimes we tend to underestimate how poorly they are seeing. And this is a simulation of how their vision can be, and it's obviously a major impact on the quality of life. So the management of keratoconus in itself is a very big topic for this discussion, but sticking to the topic of discussion today, in the mild and early cases of keratoconus, glasses would be adequate for visual rehabilitation, but the patients of moderate to severe cases may do much better if we give them the option of using a contact lens. So now there are a variety of contact lenses that can be used in these patients, starting from the soft toric contact lenses, the more commonly used gas-permeable lenses, as well as special lenses such as hybrid lenses, piggyback lenses, mini scleral and scleral lenses. The soft toric contact lenses can only be given to your patients of keratoconus who are early on. They don't have much steepening of the cornea, and the primary refractive error is a low astigmatism with high myopia, and if they are very intolerant to gas-permeable lenses. But for most of the other keratoconus patients, that is ranging from the moderate to severe type, the gas-permeable rigid lens gives them a very stable optic surface and reduces their aberrations. And plus, they give the advantage that there is no limbal touch. It's purely a corneal lens. Therefore, the patient may be more suitable for RGP lenses. The RGP lenses can be spherical, aspherical, or it can be a combination of both. In case the patient is not tolerating an RGP lens, a piggyback system, as can be seen in the picture, shows a soft contact lens as a base over which a rigid gas-permeable lens is placed, therefore improving the patient's comfort. A hybrid contact lens, as discussed, which has a soft peripheral portion and a high gas-permeable center. There are specialized contact lenses as well, but the advantage comes when you offer scleral lenses to the patient, which vault over the cornea. And nowadays, with more specialization, there are customized computer-assisted contact lenses as well, which are called the PROS lenses. Whenever we are fitting a patient of keratoconus with a contact lens, we are creating a homogeneous optic, reducing the aberrations and therefore improving the visual quality. Because there is minimum contact with the surface, there is no pressure, there are less chances of the ectasia progressing or any evidence of scarring that may tend to increase if there's a lot of touch with the cornea. And the minimum contact with limbal area will also mean that there's no conjunctival injection or intolerance to the lens. So based on the different presence of cones in the patient, the contact lens fitting has to be customized for that patient depending on the position of the cone, and the parameters of the lens are to be decided based on this. As we said, the scleral lenses, they are vaulting over the cornea, there's no contact, and therefore it is a much safer option and much comfortable to the patient, those who are not tolerating RGP lenses. And because the lens seals the bulbar conjunctiva, there is minimal tear exchange occurring under the lens, and therefore the patient may need to replace the solution that is inside the lens every 6 to 8 hours. So this is how a scleral, well-fitted scleral lens looks over the cornea with a good vault as well as minimal conjunctival blanching or any irritation at the limbal area. Traditionally, apical clearance and apical bearing were the two types of lens fittings, where you can see in the apical clearance that there is a pool of fluorescein that can be seen centrally. In the apical bearing technique, there is a apical touch, but the advantage that this lens gives is the patient gets better vision. But when using it over a long time, it can lead to scarring over that area, and therefore we have now shifted to a 3-point touch technique of contact lens fitting, where there's a minimal apical touch, a mid-peripheral bearing, and then a peripheral touch again. The most important of the lens properties that you need to be sure of before you dispense a contact lens is the lens diameter, the base curve radius, and the power. There are various trial sets available from different companies along with their recommendations. You can try with the keratometry readings, fit on a lens, and then based on the dynamic and the static fit of the lens, either increase or decrease your settings so that the patient becomes more comfortable. Dr. Krishna had discussed about the sagittal depth. What is important to remember here that a patient having the same keratometry, that is the two pictures that you can see here, even a patient with the same keratometry reading can have very different sagittal depths. And how is it important? Because if the patient's contact lens fitting has very high sagittal depth, there will be bubbles under the lens and the lens will ride low. And whereas if the sagittal depth is not enough, the lens will keep decentering. So you can modify the base curve of the contact lens, the peripheral curve, and the lens diameter to give them a complete fit along with a good sagittal depth. If your lens is riding high or riding low when you look for the contact lens fitting, you need to change the diameter, the base curve, or the edge lift, and make sure that the patient is having a centralized contact lens with minimal movement. There can be a mid-peripheral contact point along the horizontal meridian, but the lens should have unobstructed movement along the vertical meridian with each blink. A spherical over-refraction is then done once you are happy with the fitting of the lens, and whatever is the spherical over-refraction, you can make changes in the power of the lens accordingly. So this is how a well-fitting vaulted scleral lens is looking on the eye. Even if there is an area of central scarring, there's no touch in that area, so you're not at risk that if the patient is on chronic use of these lenses, the scarring may increase. Now, after all this information, how it is important to take this to clinic, I'll just be giving few basic simple examples of how it can benefit the patients of keratoconus. So this was a male patient of keratoconus. Left eye had advanced keratoconus. This was the right eye pentacam. And this is the left eye. So the vision in the left eye was very poor, 20/100 as you can see, and not improving with glasses. But when an RGP contact lens was given to this patient, we could improve the vision up to 20/20 partial. The patient was very happy with the contact lens. This was the 3-point touch technique of the contact lens fitting. Sometimes you may have a patient who's not a classic case as in just keratoconus. This patient had, 36-year-old patient, had advanced keratoconus, and the left eye had developed eye drops earlier, which are now scarred. Had very poor vision, and the patient had actually never had good vision in the left eye ever. And when the mini-scleral contact lens trial was done in the left eye, the vision improved to 6/12. So the patient was really happy because he had never even expected that he would have that good vision with his left eye ever. So after the contact lens fitting, and always for scleral lens, we need to remember that a 4 to 6 hours extended contact lens trial also needs to be done to make sure that even over a period of time, the patient is comfortable with the lens. If it's a patient even of advanced keratoconus, where as you can see, because of the thin pachy, cross-linking could not be done in the right eye, but it was done in the left eye. Even in the advanced keratoconus eye, with a mini-scleral contact lens of the following parameters, the vision could improve up to 6/9 in that eye, which was so advanced. So it's a very good option for patients where you may not even be able to do a cross-linking, but having explained that if there is progression, the fitting of the contact lens may change. So a good fitted contact lens with giving the patient good visual acuity is going to make the patient happy as well as the doctor happy. So it is to be remembered that all patients whom you are not able to improve, give them good quality of vision with glasses in keratoconus, they should be offered specialty contact lenses. In association with a contact lens specialist, the correct contact lens should be dispensed, and they are absolutely safe if they are of the correct fitting and the patient knows how to take care of the lens. And with the quality of vision that the patient gets, the patient would come back to you regularly and get more people to take the contact lens. So a happy patient will lead to a happy doctor. Thank you.